and we apply certain chemicals to it, no mechanical treatment is done, but a chemical treatment is done, and that leads to whiter teeth, a lightening of color of the teeth. See what basically happens in the mechanism of dental bleaching. These discolored teeth, they have got ring compounds. Various ring compounds are present, organic ring compounds that lead to tooth discoloration. And when we apply certain chemicals to the teeth surfaces, they result to formation of chain compounds, which are mostly colorless or lighter in color as compared to the ring compounds. And if we do not halt the process of bleaching, we keep on applying the chemicals to the tooth. It results into breakdown of the tooth structure with the formation of carbon dioxide and water. Okay, this is the final break point in the bleaching procedure. So basically, we have to halt the procedure when the chain compounds have been formed, or we can say that the tooth of color has been lightened one or two shades. If we keep on doing the bleaching, then without any marked improvement in the shade, there would be what? Breakdown of the tooth structure, breakdown of the tooth hydroxyapatite. It can be detrimental to the health of the tooth. So, if we talk about stains, for which we do the bleaching treatment, two principal category of stains are there: extrinsic, which are very common, and intrinsic stains. Extrinsic and the intrinsic stains. We all know that extrinsic means a tooth surface is discolored due to binding of certain chemicals or colored compounds on its surface. Intrinsic staining is inside the dentine more commonly. It can involve certain pulp remnants also, purple components only. But mostly the intrinsic stain is due to incorporation of certain chemicals, colored compounds into the tooth structure from inside. Extrinsic stains, they are better treated, definitely. Intrinsic stains, they respond poorly to the bleaching treatment. Now, over the years, there have been various classifications for the tooth stains. One of the most commonly used is the Matthews classification. Matthews classification of tooth stains. According to the Matthews classification, tooth stains are categorized as N1, N2, and N3 stains. What is N1 stain? N1 stain means there is a chromogen. Chromogen means there is a colored compound. A certain colored compound is present that binds to the tooth, and it imparts same color to the tooth. It is giving same color to the tooth. A colored compound is present, like we can talk about tea and coffee, certain other beverages like cola, etc. They have got colored compounds, brownish color, yellowish brown color, dark brown color, black color. They would bind to the tooth structure and impart same color to the tooth. So the discoloration would be of the same color as the compound that is binding to the tooth structure. These are N1 stains. On the other hand, when we talk about N2 stains, there is a chromogen, again, which is a colored compound. Similarly, it would bind to the tooth, but it would impart different color to the tooth. a different color to the tooth. Means suppose the chromogen is brown in color, when it sticks to the tooth, when it binds to the tooth, either chemically or physically, it would impart a color different from brown. So antiostains means the chromogen is binding but is giving a color which is not similar to the chromogen which is binding. And three stains on the other hand. In this case, there is a pre-chromogen. Pre-chromogen. Pre-chromogen means it is a colorless compound. Pre-chromogen is a colorless compound. It would bind to the tooth. It binds to the tooth. And what it gives? It gives certain color to the tooth, certain discoloration of the tooth. So basically, you have to understand the difference between N1, N2, and N3 type of stains. If a chromogen is binding and giving the same color, it is N1. If a chromogen is binding, a colored compound is binding but giving a different color to the tooth, it is N2 stain. And a pre-chromogen means a colorless compound is binding and giving a different discoloration of the tooth. It is N3 stains. Example of a N3 stain means carbohydrate rich diet. A person who is having carbohydrate rich diet, like consuming a lot of potatoes or apples, they are colorless compounds, but they can give rise to certain blackish discolorations on the teeth. Example of N3 stains. So this is one of the most relevant clinical classification given by Latu. Now, whether the stain is intrinsic or extrinsic, we have already talked about that extrinsic stains are more conducive to the bleaching procedure as compared to the intrinsic stains. Today, I'm not discussing the various causes of extrinsic and intrinsic stains. That is very much obvious. You can find out. But what I am discussing today is the bleaching technique and the procedures. So, firstly, if we encounter a bleaching tooth which needs or requires a chemical treatment, we have to talk about certain bleaching agents or the chemicals that we use. What chemicals can we use? The most common chemical is hydrogen peroxide, which is used in high concentration of 30 to 35%. And this high concentration of hydrogen peroxide is called superoxole. Okay, this hydrogen peroxide, it would break down to release nascent oxygen plus water. It is highly unstable solution, such high concentrations, which are called superoxole. This nascent oxygen that is the active ingredient. It would penetrate hydroxyapatite. HA stands for hydroxyapatite of the HA stands for hydroxyapatite and it causes bleaching. Means it would convert the colored ring compounds into colorless chain compounds. So active ingredient that is nascent oxygen. The second chemical that can be used is sodium perborate. Sodium perborate. Okay. Sodium perborate, it is a white crystalline powder. It is a white crystalline powder, and depending upon the volume of oxygen it contains, it is available as monohydrate, trihydrate, or tetrahydrate form. These are what? These are the different forms of sodium perborate, a white crystalline powder that is available. Now, this sodium perborate basically breaks down to give sodium metaborate plus nascent oxygen, which is derived from hydrogen peroxide. Similarly, there is derivation of nascent oxygen or hydrogen peroxide liberation. So sodium perborate, it gives a byproduct, that is sodium metaborate, and the active ingredient that causes bleaching of the tooth structure. The third chemical that can be used is carbamide peroxide. Carbamide peroxide. This carbamide peroxide is usually used in the concentration of 10 to 15%. And carbamide peroxide is also called urea hydrogen peroxide. Another name for carbamide peroxide is urea hydrogen peroxide. If we use a 10% solution of carbamide peroxide, Cp stands for carbamide peroxide, it would disintegrate to give 3.6% hydrogen peroxide plus 6.4% urea. Okay, so urea is a byproduct, and that's why it is called urea hydrogen peroxide. The another name for carbamide peroxide is urea hydrogen peroxide. This hydrogen peroxide is the active ingredient, and this would further break down into water and nascent oxygen that we have already seen. That nascent oxygen would cause bleaching of the tooth structure. So these are the three important chemicals. This carbamide peroxide, okay, is made into gel form. There is a thickening agent that is added to it, and this thickening agent to make it into the gel form is a polyacrylic acid copolymer, that is carbopol. This carbopol makes it thick in the gel form. What is the advantage of gel form? We have to do a limited application of the bleaching agent to the desired area of application, isn't it? If it is flowable, it is too fluid, it would seep to other areas where we do not want the bleaching agent to come into contact. So a more precise and a better application of bleaching agent is done when it is in the form of a thick gel. So what is the thickening agent added? It is carbopol, which is a polyacrylic acid polymer. Carbopol is added to it. Then we have another combination agent, that is McInnes solution. McInnes solution. It is basically a combination of 30 to 35% hydrogen peroxide plus 35% hydrochloric acid plus 0.5% ether, usually added in 5 parts, 5 parts, and 1 part. The ratio is 5 is to 5 is to 1 for hydrogen peroxide, hydrochloric acid, and ether. Hydrogen peroxide, definitely we know, is the bleaching agent. Ba stands for bleaching agent. Hydrochloric acid is the etchant. It causes microporosities onto the surface for better penetration of the bleaching agent like hydrogen peroxide. And 0.5% anesthetic ether, it is a cleansing agent that removes surface debris. It removes surface debris. So this is basically McInnes solution. So these are the four principal chemicals that we use for the bleaching treatment, starting from superoxole to carbamide peroxide to sodium perborate and a combination agent that is manganese solution. Now we talk about classification of bleaching treatment. See, depending upon the condition of the tooth that we are bleaching, either we are bleaching a vital tooth, so it is called vital bleaching, or we require to bleach a non-vital tooth, so it is accordingly called non-vital bleaching. A simple scheme of classification, principally based upon the status of the tooth. If the tooth is a vital tooth, we call it vital tooth bleaching. Similarly, if it is non-vital, we call it non-vital tooth bleaching. Now, vital bleaching is further subclassified into two types. One is in-office bleaching of vital teeth. In-office means that would be carried out by professionally by the dentist in the dental office. In-office bleaching, or it can be home bleach. Means the dentist would give the material and the instructions for bleaching to the patient, and the patient would do the bleaching treatment himself or herself at the home. That is home bleaching of vital teeth. Similarly, non-vital bleaching can be carried out in the office, which is called thermocatalytic bleaching. Means the bleaching is carried out into the dental office by the dentist, or it can be walking bleach. Walking bleach. These are the simplest method of classifying the bleaching treatment based upon the condition of the tooth that we are bleaching, either vital or non-vital bleaching. Firstly, we'll talk about in-office bleaching of vital teeth. In-office bleaching of vital teeth is also called power bleaching. Power bleaching. Why it is called power bleaching? Because we are using a highly concentrated 35% hydrogen peroxide solution, that is superoxole. And such highly concentrated hydrogen peroxide solution is really caustic to the tissues. It can be very corrosive, can cause chemical burns to the tissues. That's why it has to be used very carefully by the professional. We cannot give it to the patient to do bleaching at the home. So that's why it is called power bleaching, because a very strong bleaching agent is used, that is 30 to 35% hydrogen peroxide. What are the important considerations for power bleaching? In power bleaching, we mostly use one arch at a time. Either the maxillary or the mandibular teeth are bleached first, mostly the maxillary first. Why we bleach only one arch at a time? Because bleaching is an aesthetic procedure. It is a cosmetic procedure. The patient is seeking an improvement in shade from the baseline shade. At times, if we bleach both the arches together and after the bleaching treatment is completed, the patient may not be convinced that there has been an improvement in the shade from the baseline. That can lead to some legal implications on part of the dentist. So, to avoid that and to serve as a baseline reference, we bleach only one arch at a time. And since the maxillary arch is more aesthetically visible, the dentist and the patient both prefer that the maxillary teeth be bleached first. So, we bleach one arch at a time, usually the maxillary, simply to serve as a baseline with the reference of non-bleached arch. We can show the patient that, okay, this was your original shade. These are the improvements, one or two shades into the teeth. Second important consideration is that no LA is given to the patient. We would not anesthetize the tooth. We are doing strong bleaching on the vital teeth. So it is important that we do not give any form of anesthesia to the patient so that whatever sensitivity is there due to the strong bleaching agent is felt by the patient and we can interrupt or halt the procedure, terminate the procedure then and there. So LA is not given. Another important consideration is proper isolation of teeth. Mostly it is done with rubber dam. This proper isolation of the teeth is done to protect the soft tissues like gums and the mucosa. Why to protect the soft tissues? Because we are using a very strong bleaching agent that is 35% hydrogen peroxide that can cause chemical burns to the soft tissues. Okay. So if this is suppose the arch of teeth that I am planning to bleach, we can do a conventional rubber dam isolation, or we can apply liquid rubber dam like this onto the free gingival margin extending to the attached gingiva. Okay, it is a paste form of light curable material that is injected from a syringe. This is called liquid rubber dam. It is a paste that is available in the syringe. We apply it onto the soft tissues around the teeth, the gums, etc. And then we show light to it, the conventional light that we use for the curing of composites. The same light is used, and this hardens up and then isolates the soft tissues from the teeth so that the bleaching agent can be safely applied to the tooth surfaces. This is known as liquid rubber dam. What is the conventional rubber dam? It is made up of either latex or non-latex materials. It is a sheet of rubber dam material that can also be used if we are not using liquid rubber dam. But it is of paramount importance to protect the soft tissues. Then the bleaching agent is applied on the facial surfaces of teeth. We do not apply it on the lingual or the palatal surfaces. Applied onto the facial surfaces of teeth. Suppose this is the bleaching agent that would be applied onto the facial surfaces of the teeth. And usually it is kept for 30 seconds per tooth. We can engage multiple teeth at a time, or we can do one tooth at a time, whatever is the convenience. But usually it is kept for 30 seconds per tooth. At times, the strong bleaching agent like hydrogen peroxide, its breakdown into nascent oxygen. It can be catalyzed with some form of light or heat. Okay. After application of the bleaching agent, we can show some light, a strong light or heat application that catalyzes the breakdown of hydrogen peroxide into nascent oxygen rapidly. That would hasten the process, result in more efficient bleaching in a shorter time duration as compared to a non-stimulated bleaching. But you have to always remember that safely tolerated temperature of vital teeth is 115 degrees to 140 degrees Fahrenheit. We have to ensure that whatever form of heat application or light we are doing does not increase the tooth surface temperature more than this limit. It is in Fahrenheit because above this temperature, there are chances of pulpal damage. Our purpose is to bleach the tooth and not damage the pulp. If we talk about light, various bleaching light sources are used. Like we can use LED lights. You all know that LED light is commonly used for the curing of dental composites. Same LED lights can be used which involve cold blue light. These LED lights emit cold blue light. Okay, so there is no danger of increasing the tooth surface temperature with LED lights. They emit cold blue light of high intensity in the range of 1500 to 2500 milliwatts per square centimeters. A high intensity cold blue light. This blue light would catalyze the breakdown of hydrogen peroxide to release decent oxygen rapidly. We can also use lasers. Lasers most commonly used are the diode lasers in the range of 830 to 900 nanometer wavelength. Okay. These lasers also emit high intensity light. High intensity light that catalyzes the breakdown of hydrogen peroxide rapidly to release nascent oxygen. Okay. We can also use plasma arc light. Plasma arc light. Plasma arc light is basically a high intensity white light. It's a high intensity white light that has the potential to increase the tooth surface temperature. That increases the temperature. So we have to be very careful while using plasma arc light. As I've already told you, temperature should not increase more than 110 to 140 degrees Fahrenheit. How can we monitor the temperature? By using some form of a thermostat that monitors the temperature of the tooth surface. In this way, we proceed with the bleaching for about 30 to 45 minutes total duration. And once per week it is done for a total of 2 to 3 weeks. If there is an improvement in the shade after the first visit, then only we continue to the second and the third visit. Because at the end of the first visit only, at the end of the first session only, we'll know that this particular type of stain is responding to the bleaching treatment. And maximum for 2 to 3 weeks we do the bleaching, and beyond that it is not advisable. If there is no improvement in the shade, then it is very unlikely that further improvement would occur with any further application of bleaching agent. We have to reconsider the treatment and switch over to some other treatment procedure like application of veneers or other restorative means. What is the disadvantage of vital bleaching? One of the most frequent disadvantages is dentinal hypersensitivity. Most frequent disadvantage reported in greater than 50% cases. As we know, we are applying a very strong chemical to the vital teeth. There is a high potential of dentinal hypersensitivity. The patient would complain of hypersensitivity for a couple of days or weeks after the bleaching treatment. That is the reason that we never anesthetize the teeth while doing the vital bleaching procedure, so that if at all there is acute sensitivity to the patient, we can stop and terminate the procedure then and there. Other disadvantages include denaturation of pulpal enzymes. Denaturation of pulpal enzymes. We know that we are using hydrogen peroxide in a high concentration. So greater than 50,000 micrograms of hydrogen peroxide, if it penetrates into the pulpal surface, would cause denaturation of pulpal enzymes. That's why limited application is desirable. More than equal to 50,000 micrograms of hydrogen peroxide causes denaturation of pulpal enzymes. Damage to existing restorations. Existing restorations can be restorations like composites, or they can be restorations like dental amalgam. Okay. Although amalgam is not frequently used in the contemporary dental practice, but some of the patients can have amalgam which have been done a couple of years back. So these amalgam restorations have the potential of mercury release due to application of these strong bleaching agents. Similarly, restorations like dental composites, they can become brittle and chalky white. They can become unesthetic. There can be discoloration. They can become chalky white from being translucent due to application of strong hydrogen peroxide. So these are some of the disadvantages of in-office bleaching of vital teeth. The second category of bleaching is at-home bleaching of vital teeth. This is also called NGVB, that is night guard vital bleaching. Technique of bleaching was first given by Haywood and Heyman. Haywood and Heyman. Night guard vital bleaching. As the name indicates, there would be fabrication of a customized night guard. A bleaching tray is fabricated. Okay. So bleaching tray is fabricated. We fabricate a bleaching tray into which, so there is basically a impression of the tooth is being taken, and like this a bleaching tray is fabricated, made up of clearless. You must have seen clear aligners, you must have seen night guards. They are made up of polycarbonate materials. So similarly, a bleaching tray is fabricated into which we apply the bleaching agent, and the patient wears that tray either during the day or during the night. Now, what is the agent over here? Since it is a home applied method of vital bleaching, we cannot use superoxole, which is very concentrated. The agent used here is carbamide peroxide, that is 10 to 15% carbamide peroxide. So different bleaching mechanisms require different agents. Here the bleaching agent is carbamide peroxide in the form of a gel that is applied into the desired amount, and the patient wears the tray with the bleaching agent. So this is basically night guard vital bleaching. One added disadvantage of this carbamide peroxide is that it causes orange discoloration. Methyl methacrylate, temporary crowns. If a person is having temporary crowns in the mouth, okay, some of the crowns may be temporary crowns which are mostly made up of methyl methacrylate, and it is subjected to carbamide peroxide bleaching treatment, then there can be orange discoloration of these temporary crowns. So if we are planning a night guard vital bleaching procedure in a patient having methyl methacrylate temporary crowns, we can substitute them with bisacral crowns. Bisacryl crowns. Instead of methyl methacrylate resin, bisacryl crowns, they do not get discolored with carbamide peroxide because it is a cosmetic treatment, something which is solicited by the patient. So we have to take care that whatever temporary crowns are present remain aesthetic during the treatment also. This is one added point that you have to remember about the disadvantage of carbamide peroxide. Okay. There are two schedules for it, a daytime schedule and a nighttime schedule. Schedule of bleaching. Daytime means the patient would wear it for 8 to 10 hours for 2 to 3 weeks. Nighttime schedule means patient would wear it for 6 to 8 hours for 3 to 6 weeks. Whatever schedule is convenient according to the patient's preference and the professional engagement, you can choose them, either the daytime or the nighttime schedule. After that, the patient is recalled every week and we check for the improvement and accordingly make the adjustments. This is night guard vital bleaching. Now we talk about non-vital bleaching. Non-vital bleaching, firstly, we'll talk about walking bleach. As the name indicates, walking bleach means we are bleaching a non-vital tooth. The bleaching agent would be packed inside the pulp chamber of the tooth and the patient is free to move around. We can send back the patient. That's why it is called walking bleach. The patient is literally walking around doing the regular activities with the bleaching agent inside the pulp chamber of the tooth that is being bleached. This technique of bleaching was given by Nutting and Poe, walking bleach. And the agent that we use most commonly is sodium perborate. Sodium perborate. Okay, so now you can see that depending upon the technique of bleaching, the bleaching agent we are changing. Here the bleaching agent would be sodium perborate. It can be mixed either with hydrogen peroxide or with saline. Sodium perborate with saline or sodium perborate with hydrogen peroxide to make a paste. Saline is the preferred method. It is more safer. It produces a subtle bleaching, lesser aggressive bleaching as compared to hydrogen peroxide, but it is a better alternative. What is done in this? There's a non-vital tooth, means a RCT treated tooth is there. And we have to improve the shade of such a tooth which has been discolored and root canal treated. So we remove the obturation. 1 millimeter apical to cemento enamel junction. The root canal has already been obturated. Suppose this is a tooth which requires bleaching. Okay. And after gaining access to the pulp chamber, we would remove the obturation. This is the obturation in the tooth. Okay. This is the cement to enamel junction. And we remove the obturation 1 millimeter apical to cement to enamel junction. Okay. Secondly, 2 millimeter thick layer of resin modified glass ionomer cement is applied on the aperture obturation, or simply we can say on the obturation in the root canal. We remove the obturation 1 millimeter apical to the CEJ, especially the facial surface CEJ, so that no discoloration of the tooth structure happens over there. And then we apply a 2 millimeter thick layer of, this is a 2 millimeter thick layer of resin modified glass ionomer cement. This 2 millimeter thick layer, it is called RMGIC barrier. This is a resin modified glass ionomer barrier. What is the need for barrier? We are applying bleaching agent inside the pulp chamber of the teeth. So there is always a risk that this bleaching agent can seep inside the root canal. It can go into the thin cervical dentinal tubules, and it can induce resorption of the tooth. It can induce apical periodontitis in certain situations. So to prevent the bleaching agent from seeping down, we want just the clinical effect into the crown and nothing is to be done into the root. So RMGIC barrier is used. This is a 2 millimeter thick barrier. There are two terms which are used to describe the shape of barrier. When a properly used barrier of RMGIC is placed, we describe it by two terms in buccolingual direction. When we see the tooth in the buccolingual direction, this barrier has the shape of ski slope. You must have seen the mountain slopes used for the skiing. Similar shape is produced in the buccolingual direction. And when we see the barrier in the mesiodistal direction, we have applied a 2 millimeter thick barrier onto the obturation. Okay, so 1 millimeter would be below the CEJ, 1 millimeter would be above the CEJ. This barrier is described as having a shape of ski slope when viewed in the buccolingual direction, in the shape of bobsled tunnel. What are these? These are the two terms which are used to define the shape of the RMGIC barrier, either in the buccolingual or the mesiodistal direction, respectively. In the next step, what is done? Sodium perborate is mixed with saline. We know that sodium perborate is a white crystalline powder. It is mixed with saline. It results into formation of a slurry-like paste, and this paste is then packed into the pulp chamber. This is sodium perborate plus saline packed into the pulp chamber. And on top of that, we would close the pulp chamber with a temporary material. A thick temporary material is applied, usually in the thickness of 3.5 to 4 millimeter. Thick layer of temporary is applied so that no percolation of the fluids into the pulp chamber or vice versa occurs. This is known as walking bleach. This is a sequence of doing the walking bleach. The patient is recalled after 1 week. We assess the progress of the treatment. Has there been any improvement in the shade or not? And accordingly, we can give another repetition. We would remove the old material from the pulp chamber, make a fresh mix of sodium perborate with saline, pack it, and again send the patient back. If there is some improvement and we want more improvement, we can continue the treatment for a couple of weeks. But every time the patient is free to move around, go back, that's why it is called walking bleach treatment. On the other hand, if the similar treatment is done inside the office, it is called thermocatalytic bleaching. Thermocatalytic bleaching. Thermocatalytic bleaching, basically the sequence would remain the same. Suppose this is a root canal treated tooth where we are planning to do the bleaching treatment. Okay. Similarly, we would remove the obturation to 1 millimeter below the CEG. Okay. Then on top of it, we would apply a RMGAC barrier, similar barrier that we have already seen. Then we would mix sodium perborate with saline and pack it into the pulp chamber. Now, instead of closing the tooth from above and sending the patient back, we would catalyze the breakdown of sodium perborate with a heated metallic wand. A heated metallic wand is placed inside the pulp chamber. Okay, it is a stick-like device. It is heated, either manually heated over the flame or it is electrically heated. A heated plugger-like device is placed inside the pulp chamber, coming in contact with the bleaching agent. So that heat would catalyze the breakdown of sodium perborate rapidly into sodium metaborate and active ingredient, that is nascent oxygen. This is known as thermocatalytic method. It rapidly disintegrates sodium perborate into the active bleaching agent. Thermo means heat, heat catalyzed mechanism of non-vital bleaching. As it is done inside the office only, it is different from non-walking bleach in that aspect only. Otherwise, all the steps remain the same. This is thermocatalytic method of non-vital bleaching. We talk about the disadvantages of non-vital bleaching. Then the most common disadvantage is ECR, that is external cervical resorption. External cervical resorption. Why would external cervical resorption occur? It is the important to put a good thick barrier of RMGIC. We know that dentinal tubules are present, especially in the thin cervical area. If proper isolation of the dentinal tubules is not done, the bleaching agent would seep from the pulp chamber outward into the dentinal tubules of the cervical area and can induce a resorption that is called external cervical resorption. Always remember that ECR is one of the most common disadvantage side effect of non-vital bleaching. But bleaching is not the most common etiology of external cervical resorption. This I have already discussed in one of the previous sessions where I took tooth resorption, and I have told you that external cervical resorption, most common reason is not bleaching, but ECR is the most common side effect of this external non-vital bleaching. Now, it is very important to note that ECR is not always evident immediately. So, it can manifest even up to 4 years after bleaching. A tooth has been subjected to non-vital bleaching and it can manifest even after 4 years of non-vital bleaching. So it is important that long-term follow-up of such patients is done so that if there is any evidence of external cervical resorption, adequate intervention can be taken. Then there can be periapical inflammation, which is a less common effect, periapical inflammation, which happens due to seepage of bleaching agent inside the root canal. But definitely you have to remember that external cervical resorption is the most frequent side effect. Now, another disadvantage related to especially non-vital bleaching is that compromised bonding of composites. Compromised bonding of resin-based composites. We all know that resin-based composites are mechanically bonded with the help of certain bonding agents, okay, onto the tooth surface. Now we are doing a non-vital bleaching in a tooth. Even after a couple of sessions, we realize that the shade improvement is not as required. And to further enhance the shade of such a tooth, we need to place or do some composite restorations, maybe a composite veneer on such a tooth. But because of the residual hydrogen peroxide or oxygen metabolites, we have packed the pulp chamber with bleaching agents. Okay, these residual active oxygen metabolites, they compromise bond strength of composites. So, bonding of composites to bleached enamel and dentine is a challenge because of the residual active oxygen species which are present into the tooth structure after the bleaching treatment. The bonding is not successful because they break the carbon-carbon bonds and prevent successful bonding. So it is always justified to wait 2 to 3 weeks after bleaching for optimal bonding. If we are planning to apply composites to bleached enamel and dentine, it is justifiable to wait 2 to 3 weeks for optimal bonding. If you are getting a question and it is asking you how much you have to wait for the best bond strength, and 2 and 3 weeks are the separate options, then stick to 3 weeks. If we are talking about a range, it would be 2 to 3 weeks. A second set of questions there which is asking you about the minimum time that we have to wait is 1 week. So depending upon the language of the question, you have to answer accordingly. Optimal time is in the range 2 to 3 weeks, singularly 3 weeks. Minimum time that we have to wait is 1 week. Okay. Certain agents or compounds can be used to remove residual bleaching agents from the tooth structure. Okay. Instead of a waiting period, we can use certain agents or chemicals to neutralize the bleaching agents. These chemicals are alpha tocopherol. Okay. Catalase. Catalase is an enzyme that breaks down hydrogen peroxide. Okay. Like these chemicals, catalase usually requires 3-minute application. into the pulp chamber to neutralize the residual hydrogen peroxide. We can also use sodium hypochlorite rinse to neutralize the bleaching agents. These are certain chemicals that can be used to neutralize the residual bleaching agents and improve the bonding with the composites. But it is always advisable to wait for a certain period of time, and that optimal time is 3 weeks. These are the different types of your bleaching treatments that are advocated. Best results are obtained for light yellowish brown discoloration of bleaching treatment. Dark blue and black stains, they are less conducive, less favorably they respond to the bleaching treatment. Okay. Also, bleaching is generally not indicated for young teeth. Young teeth means which have got large pulp chambers. In young patients, especially subadult patients, they have got large pulp chambers, and application of strong bleaching agents can cause severe damage to the pulpal enzymes and can even denature the tooth or can even degenerate the pulpal tissue. So it is not indicated for such cases. These are the important aspects of your dental bleaching. And with this, I conclude the today's session. As we are entering the new year, from my side, I wish everyone a very happy new year 2025. Best wishes to you all for the forthcoming examinations, also, all those who are appearing for the NEET MDS 2025. Definitely, their preparation must be in the last lap. So, my best wishes for you all. Keep reading. Till then, see you next year. Till then, goodbye. With this, I'm signing off. Thank you.